Yes, Dr. Cox talks funny. At one of his lectures he said, and I quote, "Nonlinear dynamic systems exhibit chaotic phenomena that often appears to be random. These stochastic processes involve large numbers of variables and their temporal dimensions approach infinity. But we can approach interpreting, analyzing, modeling, and simulating these dynamic, autoregressive, adaptive processes using stochastic algorithms to factor out the noise in these complex systems and reveal the underlying structure or pattern of these processes. As a result, we can describe our statistical characteristics in ways that conventional deterministic models cannot offer."
Wow, sounds like a really interesting lecture. Maybe he should be a rock star. Seriously though. It is a very accurate but not very informative description. Dr. Cox obviously spent too much time hanging out with actuaries. What he really means is that there is a very simple statistical explanation for why insurance works. When insurers write large numbers of policies, they benefit from the central limit theorem. The more policies they write, the closer to average their overall costs. The number of claims an insurer gets does not increase arithmetically as the number of policies increases. The more policies an insurer writes, the closer to the average for the population the number of claims they get will be. As an individual, you either have a claim, or you do not. But if you are an insurer and the average number of claims for the population is 1 in 1,000, and you write 1 million policies, you are going to get around 1,000 claims every year. Big insurers never get no claims, nor do they ever get 1 million claims.
Okay, but explain about Sally. Why did the managed care company want Sally to be discharged?
Actually, the managed care company doesn't really care about Sally being discharged. They act as though they do, because it promotes misunderstanding of what is really happening. It is a good example of smoke and mirrors. When Constance Sorrow's hospital signed the contract with Really Greedy Managed Care, the hospital, not Really Greedy, became Sally's insurer. But Constance Sorrow's insures a lot fewer people than Really Greedy. Let's use the example we have been talking about. Suppose that Really Greedy can cover the claims of 1 million policyholders for $287 in premiums per person. Constance Sorrows only covers 1,000 people. We saw that if 1,000 people share risk, they would each have to contribute $2,000 to cover their combined costs. Small insurers, because they are very inefficient, have to charge a lot more per policyholder. Really Greedy, because it is large and efficient, only charges $287, so it cannot give us $2,000 per policyholder. But we need $2,000 to cover our claims costs.
This took me a while to see, because I originally thought that Sally's managed care company was paying for Sally's care. So did Sally. Explain to everybody what happened? If we needed $2,000, how much did we get? Really Greedy can't take in $287 in one hand and pay out $2,000 with the other, can they?
Good point. Actually, Really Greedy gave us a lot less than $287, only $150. But that is too far afield. I always knew that we were paying for Sally's care, not Really Greedy. But I did not understand the problem of inefficiency. I always thought that our average costs were the same as Really Greedy's average costs. But I learned from Dr. Cox that there are two kinds of average costs. The first kind is called the expected average cost. All insurers have the same expected average cost. The second kind is called the actual average cost. The actual average costs are the actual costs of patient care. Actual costs are very different for small and large insurers.
Yes, Dr. Cox says that large insurers' actual average claim costs are very stable, so they almost always earn profits. But he says that small insurers' actual claim costs wobble around the average like a BB in a freight car. While a lot of small insurers' actual costs are close to average, some are very low and some are very high. Some small insurers make very high profits and some small insurers go bankrupt based on size alone.
Excellent description, Mary. Dr. Cox says that when healthcare providers become small and efficient insurers, some of them make a lot of money and some of them lose a lot of money, even though most do okay. But the ones that lose a lot of money may become bankrupt, becoming acquisition targets. In fact, they are often acquired by the managed care organizations, or insurers, that caused the problem. Sally's care, along with the costs of care for several other Really Greedy patients, was so expensive that we almost had to close our doors.
I remember that. It was a horrible time. A lot of our best nurses were going to leave and everyone was really tense. In many ways it was the same thing I experienced with Sally, but everyone was having the same bad dream.
Really Greedy offered to buy us out for 10 cents on the dollar. We were lucky. A really rich board member gave us a loan that helped us weather that storm. We stayed open, but there was another local hospital that did close. Their board decided that Really Greedy's offer was not worth taking, and it would be better to just close than let the good name of their hospital be used by Really Greedy. Now, we no longer accept patients from Really Greedy unless they pay our bill charges.
So, basically, when healthcare providers, like hospitals, nursing homes and home health agencies assume the responsibility for managing insurance risks, they become tiny, very inefficient insurers. Their financial results are much more variable than when large insurers manage similar insurance risks. Their inefficiencies create financial jeopardy. Some healthcare providers profit and some providers fail. The ones that fail are often acquired by the people that caused their problem.
Perfect, Mary. And the really interesting thing is that there doesn't even need to be a formal agreement. Dr. Cox explains that it doesn't matter whether the healthcare provider is responsible for the costs or is merely accountable for the costs. It also doesn't matter whether this happens in a private enterprise system like the United States or in socialized systems like Great Britain and Canada. The smaller the unit of evaluation, the more variable the actual average costs and the greater the need on the part of providers to limit costs.
Oh, I know this part really well. When I refused to discharge Sally, everyone glared at me for weeks. My nurse manager and his supervisor called me in and berated me numerous times as Sally's stay grew longer. The first time you and I met, you passed over a list of the costs for Sally's care and blamed me for them. I felt so bad. I even thought about resigning. I also thought that I would never stick my neck out again for a patient. But I felt I was right. Sally needed to stay in the hospital. So I stayed, and I decided to do something about it because I thought I was being treated unfairly.
Sally, you were treated very unfairly. You did the right thing for your patient, and now I know how important that is. In big insurance companies, a high-cost claim doesn't stand out, but in a small hospital, a single, high-cost patient gets too much attention. A lot of doctors and nurses are not as brave or committed to their patients as you. That isn't the way I saw things back then, but I see it now.
Yes, as a nurse I can say that my stress is a lot lower now. We nurses do need to be more mindful of costs, but it should never come at the expense of our patients' needs. And we really appreciate not being pressured when a patient needs more help.
Yes, and as a CFO I can say that my stress level is down too. We are a much better, more organized hospital now, and our nurse retention rates are near 100%. All it took was understanding what was really happening and doing something about it. With your help, and the help of a lot of nurses and doctors, we learned how important it was to really empower nurses by making sure they had equipment and supplies and the support of managers and executives. Most finance people think they save money through tighter inventory control. But it really just wastes a lot of nurses' time. When we considered how much nursing time was wasted looking for equipment and supplies by the most valuable members of our staff, the people who take care of our patients, we stopped a lot of things we were doing wrong.
Oh, Dr. Cox just sent me a text. He says we did a great job explaining this.
Well, that is either a really big compliment or he is just too lazy to come by.